Okay, I need to back up because I did forget something on here that I needed to cover. We talked about mucus and those goblet cells in the nasal cavity trapping mucus. We also have some other things in the upper respiratory system, not necessarily the nasal cavity, but the pharynx. We have cilia. And what is cilia? Yeah, so cilia is just little hairs that are off of the cells. So on that epithelium, we have cilia lining that respiratory tract. So the cilia up here in the upper respiratory tract beats this away. And it moves the mucus down through the pharynx, not into the larynx, but yes, we do have mucus down in the larynx, but we'll talk about it in a minute. But it moves all this mucus up here, which is more or less just boogers and snot, down into the esophagus, and it goes down into the stomach. So we're made to do that. We're made to swallow mucus, and you swallow it all day long. You just don't really think about it. But when you're swallowing mucus, which may have bacteria or viruses trapped in it, why are we made to swallow it? What's the purpose of that?
Your body doesn't digest itself.
Keeps the airways open.
Keeps the airways open, keeps us healthy.
It cleans it out, doesn't it?
It will kill it.
It's kind of like
Because what's in our stomach? Hydrochloric acid. Hydrochloric acid is in the stomach, one, to help with digestion. It will kind of tenderize meat. It doesn't digest it. But one of its main functions is to kill things. So as we're swallowing mucus or eating boogers, it's okay because we have hydrochloric acid in our stomach to kill it. That's what it's for. So at the same time, in the lower respiratory tract, we have cilia. It's just beating in the opposite direction. It's moving the mucus up from here, so then we can either cough it up and spit it out, or we can get it up further enough so then it can slide back into the esophagus and we can swallow it down. Problem with cilia, with your smokers, it makes that cilia go to sleep. So it puts it to sleep and the cilia doesn't move. So what happens to the mucus in your lungs? Yeah, it just sits there. And bacteria like warm, moist areas. So inside your lungs is nice and warm and moist. So your bacteria will proliferate. It'll grow. And that's why those smokers are always at high risk for pneumonia. Because they don't move that mucus. Another problem will happen is your smokers will quit smoking and then they really start coughing and spitting up a bunch of mucus. Why is that? Yep, exactly. The cilia wakes up and it's like, oh my gosh, look at all this mucus. Let's get it up and out of here. So then it starts moving. It wakes up and they start coughing and hacking. But it'll eventually, once we clean out the system, you'll stop with all the coughing and hacking, and they do get better. That brings us up to neural control. So the brain, unlike the heart, which has internal pacemakers, so it can stimulate itself, the lungs do not. We have to have it controlled by the brain. Because the lungs, all those muscles that were doing the breathing, even the diaphragm, they are not smooth muscles. They're skeletal. So what was the big thing between skeletal muscle and smooth? What's the big difference between the two? They are stratified, but what's the difference? Yeah. So what kind of control do we have over skeletal? Voluntary, yeah. So we can consciously say, raise my hand. Whereas I can't say, okay, stomach, start rolling. I can do my abdominal muscles, but I can't do anything about the smooth muscle that makes up my stomach or my intestines. You know, when you got to poop, you got to poop. You can't say, oh, no, no. But you have skeletal muscles that make up a sphincter to hold it. That's all skeletal. So, skeletal is voluntary control. So all the respiratory muscles that we use, including the diaphragm, are voluntary. They're skeletal. But we do have some neuro or autonomic nervous system that is controlling our breathing. We can override that. Like right now, I'm having to override my breathing to do the talking and projection of my voice. So, inspiratory centers, primary respiratory center, that is found in your medulla. Your medulla is it's the lowest part of the brainstem. So you have the medulla, and then the one that pooches out is the pons. So there's medulla, and then there's pons. That's why if you have a brainstem injury, you're probably gone. Yeah, there's not really anything we can do with a brainstem injury for the most part. So, inspiratory center is your primary respiratory center. That's the one that's doing the main breathing. Your apneistic center, so like apnea, increases the length and depth. So that can kick in if oxygen levels are detected in the tissues to be low. Then that will kick in. This is in the pons. So medulla is the main guy that does the breathing. The one up above it, the one that pooches out, the pons, just kind of fine-tunes the breathing. Makes us have a rhythm to it. Your pneumotastic, it kind of counteracts these things. Where this is increasing depth and rate, your pneumotastic is saying, whoa, 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 slow down. So it's in the pons as well. These two are in the pons. It's making our rhythm the way it is. It's saying, whoa, don't inflate too much, slow down, come back down, don't breathe too fast. So you constantly have your sympathetic and parasympathetic nervous system working against each other. The expiratory center, this is one of those where we can override, and this would be like singing or talking loudly. That's where your expiratory centers are going to come in. So, oxygen levels in the tissues, if those do decrease, we have some chemoreceptors that are picking up information in the carotid arteries, and they're detecting them constantly and saying, oh yeah, our oxygen levels are a little low. They'll tell you to increase your breathing. Big deal is your hydrogen ions. So this is coming from your carbon dioxide. Carbon dioxide itself is not acid, but when it breaks apart or dissociates in the plasma, it becomes acidic. It produces carboxy and hydrogen ions. Hydrogen ions is what gives you your pH or your acid level. So, not that carbon dioxide is an acid, but think of it like an acid. So if you have a high level of carbon dioxide in your blood, are you going to be acidic or alkaline? You'll be very acidic. So on a pH scale, where would you be? It goes from 0 to 14. You would be close down here. And actually, blood has a very fine window. You have to know this number. Your pH for your blood is 7.35 to 7.45. You have to know that number. So, normally our blood is sitting where? Far is it acid or a base? So it's normally, this would be considered neutral on a scale. Normally it's sitting slightly what?
Slightly, it's like right above it.
Right above neutral, because 7 right on the line would be neutral. So if this side is acidic and this is alkaline, our blood is slightly alkaline. So if we slide down to 7.33, you're going to be considered what? Acidic. If you slide up to 7.46 or 7.47, you're going to be considered alkaline. And it's small variations like that you will see problems in a patient. You won't see a pH of 7.3. because they're probably dying. That's how small and slight the changes can cause drastic problems inside you. So if I have a lot of CO2 in me, that means I'm not breathing. So if you give me a bunch of morphine or you take a depressant like alcohol and you drink too much and you suppress your breathing and you're laying there and you're not breathing but 8 breaths per minute, because what's the normal respiratory rate? 12 to 20. Normal respiratory rate. You got to know it. 12 to 20. So if you're breathing 8, that means I'm not blowing off, spitting out a bunch of CO2. My CO2 levels go up, up, and up. Then you become very acidic. You move down this scale. You get too acidic, cells start to die. Cells die, tissue dies. Tissue dies, organs die. Organs die, organ systems die. If organ systems die, you die. It may take a bit, but you will die. So in very anxious people that hyperventilate, you breathe really, really fast, where are your CO2 levels going to be? High or low? They'll be low. Why is that? Why is if I'm hyperventilating, my CO2 levels are low? Because why?
It's moving, all the CO2's moving out.
Yeah, you're spitting it out real quick. You're blowing it out. So your blood becomes very, because I don't have a lot of acid, because I don't have a lot of CO2, it becomes very what? Alkaline. That can be a problem. You can pass out from that even. So our blood likes to stay in this range. We can't be very acidic or very alkaline. Either way, we will cause cell death. So hyperventilating, what do they make you do when you hyperventilate? Yeah, they make you breathe into a bag. And you think, well, God, that's a real medical, treatment there. You have me breathe in a bag. Because what's that doing? What's that do when you breathe in a bag?
All the CO2 goes back in.
Yeah, you suck it back in. You spit it out, but then you suck it back in and you think, well, I don't want a bunch of CO2. I want oxygen. No. Your biggest driver for healthy people is what? What makes you breathe? Oxygen or CO2? What makes you breathe?
CO2.
It really is CO2. Because think about if you were to take a deep breath and hold it. It's not that you don't have enough oxygen because you just sucked in a bunch. But what's happening as you're sitting there holding your breath? What are your cells doing as they're working away?
Putting oxygen and pumping CO2.
They're pumping a bunch of CO2 out. You're not blowing it off, so that level's going up and up and up. What will happen if you sit there and hold your breath long enough? You will pass out. And what will happen once you pass out?
Stop breathing.
Yeah, you'll blow the breath out and take a breath in and start breathing normally. So when those little ones say, well, I'll hold my breath, go ahead, hold your breath, because you'll eventually pass out and you'll breathe normally. It's no big deal. So for a normal, healthy person, CO2 is your driver to breathe. When CO2 levels get really high, like exercising and running, your CO2s will, those muscles are really working hard. CO2 levels build, you want to breathe. You will have patients that are abnormal, like emphysema, COPD patients, where their CO2 levels stay high because they're not able. What happens with COPD and emphysema, the elasticity of those small, fragile alveoli get really stiff, so they can't inflate and deflate, and after a while, inflating, they burst. And so instead of being small little air sacs, individual air sacs, they burst open and they can be one conjoined big sac. And that sac, without the elasticity of that connective tissue around it, will not contract down and exhale anymore. So unlike asthma patients, your COPD and emphysema can't get air out. Asthma can't get air in because of the constriction. These, the sacs break and they're not elastic. So they can't push air out. Air just sits in there. So their CO2 levels go way up because that old air is just sitting there. And we're not exchanging CO2. So CO2 levels stay high. Their body adapts to it. just like you sitting in here, and if there was a perfume smell, after a while your brain says, okay, we're going to ignore it, and you don't smell it anymore, kind of like car fresheners in your car, because you're not doing anything about it. CO2 levels stay high, the brain finally says, okay, we'll ignore it because you're not doing anything about it. You're not fixing it. We can't fix it. So their driver to breathe becomes oxygen levels. So those COPD and emphysema patients in the hospital, we do not put them on 6 liters of oxygen. 2 to 4 liters, and that's about it. You don't put them on a bunch of oxygen. Because if you were to crank that oxygen up, keeping in mind oxygen is their driver to breathe, so now their oxygen levels are way up here, what are they going to do? They're going to quit breathing, and they will. They'll stop breathing on you. So bad deal. We don't like to put them on a lot. So that's the big thing about hydrogen ions, CO2. So try to think of hydrogen ions or your pH scale, the acidity of it, as CO2. CO2 as an acid. And it's only when it dissociates, but think of it as an acid. The stretching, so we have stretch receptors inside the lung tissue itself. So when they inflate and get really big, those stretch receptors send that message to the brain, and the brain says, whoa, 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 too much. You know, relax. Don't stretch too much. Pain and emotion, we know how anxiety or pain, if you're hurting, you breathe really fast. So that is that limbic system, autonomic system that's kicking in, telling you to do those things. And we've all had this, irritants. So whether it's mucus or something is down in your airway, or think about when you aspirate water or pop, you're sitting here and you do not want to cough, do you? In front of the whole class, or you're in some meeting, and lo and behold, it starts to tickle, and you try to suppress it, but can you in the end? No. It is out of our control. And it's because they do have receptors down in the lungs picking up that stuff, and as soon as something foreign comes down in the airway, we cough. Because it's protection. It's a reflex, a cough reflex. It protects our airway. We're not supposed to have anything but air down in it. Main muscle, what was the big muscle that does our breathing? Yes, it's the diaphragm. He's the big guy that does all the breathing for us. Felt like I was missing something, but okay. So how air moves in and out is kind of like how gas exchange even happens, or diffusion. Remember, diffusion was particles. If we have a bunch of particles in this side and we only have 2 over here, they're going to move from the area of greater concentration to the lower. Same thing with pressures. Atmospheric pressure, if it's really high out here compared to the lungs, then air is going to flow in. So on exhalation at the end, when we've squeezed those lungs down and there's no air in there, it's a negative pressure. It's lower than out here. So when we go to breathe in, air just rushes in. So when we start to pull, those intercostal muscles pull this girdle of a rib cage up and out, and our diaphragm pulls down, then it creates a negative pressure inside those lungs and air rushes in. Because it's higher out here than it is inside. When we go, once it fills completely up, then the pressure inside the lungs is greater inside than it is out here. So then it's easy to just blow out. Everything relaxes, diaphragm relaxes back up, and it's passive, and we just blow it out. So the only time, let's see if I can talk about difference in air pressures. Okay, when pressure in the lungs drops lower than atmospheric, so there's less air in the lungs, what are we going to do? There's less air inside than there is out here. Yeah. We will breathe air in. Air will flow in because there's less air inside here than there is out here. Okay, this is where I need to talk about Okay. We said on those visceral pleura laying on top of the lungs and the parietal pleura that is lining the inside of the thoracic cavity create a pleural cavity and it secretes a pleural fluid. That fluid is very similar to water. What happens to water again when we were talking about bonding? We talked about covalent and ionic bonding, but we talked about a third one. Hydrogen bonding. And what does hydrogen bonding do again to the surface of our water?
Makes it hard as concrete.
Yeah, it makes it as hard as concrete. Water tension, because all those water molecules are attracted to each other and wanting to hold hands with the other water molecule. So they're constantly attracted. So, naturally, our lungs want to collapse. They're constantly wanting to collapse on us. So, in here, this cavity, one thing that prevents that is water tension or hydrogen bonding, that attraction. So, when this membrane on exhalation pulls away and this one stays here, this water's like, whoa, wait a minute, where are you going? Come back. So it prevents those lungs from collapsing because they're trying to collapse constantly because of these little guys here. These little guys, inside them, lined inside them, yes, it's filled with air, but just on the inside surface of them is water. And this water is, we have to have it there for gases to diffuse in it. Because you have to have some type of solute or liquid for gases to move across. So there is a little thin layer of water inside those alveoli so that oxygen and carbon dioxide can move around in there and exchange. Blood has its own water, plasma. So water tension inside those tiny air sacs in a big circle are constantly pulling on each other and wanting to collapse that lung. Because if you start collapsing alveoli, then a bunch of them start to collapse, all of them collapse, then you can have lobes collapse. So you could have a right lower lobe collapse, you could have the whole lobe collapse, or you could have both lobes collapse. Right side, you really don't want collapse. That's the big guy. He does about 55% of your breathing. But you can still live. You got this side. So, water tension, the reason we fight that with the water tension inside those membranes. So we fight the collapsing of those tiny alveoli with the water in here, that fluid. But we also secrete something that is inside these alveoli. And it's called surfactant. Surfactant, I've told you how important protein is. It's another protein. It's a lipoprotein. So lipo means what? Fat. So what happens when you have fat and water mixed together in a bottle? Yeah. They don't really mix, do they? They never mix. So fat will kind of separate and break those bonds of water. So if you had a sheen, if you had fat on the surface of the water when you're diving in, it wouldn't have the water tension like it would if it was just all water, because it breaks those bonds of hydrogen where they can't hold hands anymore. So surfactant is needed to prevent those hydrogen bondings from collapsing those alveoli. What's the big issue if you have a baby born at 24 weeks? They don't. They can't breathe. So what will happen is they'll come out on delivery and you'll hear the wah! And then that's it. You'll hear one, but you won't hear a second one. Why is that? They'll suck in and you'll hear the air passing the vocal cords and you'll hear a cry. But on the second one, after the air is removed, it's out, we exhaled, and those lungs collapsed. Why do we not hear a second cry?
Because of the water, there's nothing.
Yeah, there's no surfactant.
So
Before 28 weeks gestation, there is no surfactant produced. The baby hasn't started producing it yet. Because in the womb, it doesn't need to breathe air. It does practice. It practices using those muscles by breathing that amniotic fluid in and out of its lungs. And it also swallows the amniotic fluid to get the digestive system going as well. But on this, yeah, the lungs work fine. Physiologically, everything's working good. No surfactant. So they finally figured that out. So what they'll do now, because babies at 24 weeks are viable, we can keep them alive. It's not easy, but we can keep them alive. When they start giving the mother protein injections or hormone injections of surfactant, so that they'll start stimulating that baby to start producing it if they know that they're going to go early.
Now, if they know, they give them all the steroids and